in HIV-infected pregnant women. This will be delivered by Dr. Erwin de Mesa, the President of the Philippine Infectious Disease Society of OBGYN.
Good morning. Good morning, everyone. First and foremost, thank you for attending despite the heavy rains. So, really fewer, and most likely because of the involvement of an innocent child or an infant in the prevention. During this time. So again, the role of observation plays a major. The observation plays a major role as always. Um, the action, the observation plays an active management in the prevention of mother-to-child transmission. So let's start with stating that 90% of all the traffic HIV infections came from mother-to-child transmission of HIV. And the transmission actually happens in every aspect from the time of pregnancy, during labor and delivery, and even postpartum when the mother decides to breastfeed. The transmission rate of HIV from an HIV positive mother can actually be reduced or has been reported as high as 15 to 45% in that 45% in the absence of any intervention. And actually, the rate can be reduced to below 5% in more recent evidences as low as less than 2% with the following effective interventions, like offering HIV testing, giving the antiretrovirals in time during the pregnancy, providing with appropriate antenatal care, the decision of providing the right obstetric interventions, and the choice of the newborn feeding. So that an HIV positive mother can actually give birth to an HIV-free baby. So, just an information to all, the goals of management of HIV in pregnancy is number one is the prevention of mother-to-child transmission. So that is actually the main reason why we are always measuring time. We receive patients late in pregnancy when they diagnosed with their HIV infections. So aside from the prevention of mother-to-child transmission, we also manage HIV infection and its complications during pregnancy. So as an overview of care, to be able to have a successful prevention program, we should be able to include all the measures optimal in the identification and the long-term management of HIV-infected pregnant women. Okay, so starting from the routine HIV testing that we offer to our pregnant women, the initiation of ART, the laboratories that has to be done, okay, the right antenatal checkup, the decision of labor and delivery, the infant ARV prophylaxis, formal family planning, the choice of infant feeding, linkage to care, adherence counseling, and everything. Okay, but I will center my discussion on the role of antiretroviral therapy in HIV-infected pregnant women. So the objective of my lecture is to identify the role of ART or antiretroviral therapy in the management and care of HIV and AIDS among pregnant women and their infants. Second, to determine the gaps on the knowledge and practices of HIV prevention from mother to child transmission. And lastly, to develop resolutions to HIV and AIDS related problems during the childbearing age, during pregnancy, for infants, children, and adolescents. So as an outline, I'll be discussing the efficacy of antiretroviral therapy during pregnancy, the safety of the antiretroviral treatments, and their issues and concerns. So antiretroviral therapy is actually the cornerstone. So this is the major development or discovery in the management and care of HIV pregnant. In HIV. Okay? So staying with the goals of management with HIV in pregnancy, antiretroviral pregnancy has the chance of reduces reduction of perinatal transmission and treats maternal HIV disease during the pregnancy, such that the incidence of perinatal transmission of HIV can be estimated or can be reported to less than 2% with its widespread use, with its widespread use during pregnancy. The recommendations on HIV in pregnancy has two major recommendations. No? So we have the recommendations coming from research settings such as the United States, Europe, and Australia, and we have also resource limited settings. Okay, so there are different countries has different recommendations. We're going to think of it. The bottom line here is they just have one objective, the management of HIV in pregnancy. We just want to prevent maternal to child transmission. So the recommendations of the following international societies, they may be coming from the rich countries or the ones that caters to the developing countries. They are consistent, they are unanimous in expressing the role of antiretroviral, the use of antiretroviral therapy during this time. The same way, locally, the Department of Health, as well as the society, the Philippine OBGYN Society, and the Philippine Infectious Diseases Society for Obstetrics and Gynecology are also consistent in supporting the use of antiretroviral drugs during pregnancy. So the question on when to start ART or the antiretroviral therapy. Okay, so the recommendation says that ART should be initiated in all pregnant and breastfeeding women living with HIV, regardless of their clinical stage or their CD4 cell count. And this treatment should be continued for life. The use of antiretroviral by pregnant women and their children is actually the most important intervention in the prevention of mother-to-child transmission. Okay, so the start or the start of the antiretroviral use, specifically during the early part of pregnancy, plays a major role. As a matter of fact, the reason, or I mean, the efficacy of antiretroviral therapy preventing transmission has been decided with the following, because of the following evidences and trials. And they have solved that combination of regimen is more effective in reducing HIV transmission than using a single regimen drug. And they have identified that using a three-part strategy, that is using your ART as early as antepartum or the moment that the patient was identified to be pregnant. It will also be used in partum while the woman is having labor and during her delivery. And to be given also for her child or the infant immediately within 6 to 12 hours ideally from the time of delivery. It's more effective than just giving it in postpartum or after postpartum or postpartum. It was also identified that starting ART earlier in pregnancy is more effective in reducing perinatal transmission than starting that day. As a matter of fact, there are studies that have shown that that the decrease of there is a decrease of 8% for every week. Okay, that antiretroviral has been started during pregnancy. Let me show you the mechanisms of transmission, okay, for what happens during a woman becomes pregnant. It is identified again that 25 to 40% of transmission happens during pregnancy or in utero. So the pregnant woman transmit her infected blood to her baby while the baby is still in her womb. And the increase of transmission, there's increase of transmission as high as 50% when the woman decides to, when the woman enters now labor delivery. So the longer the delivery, there's always a high chance for that woman to transmit the infected fluids to her baby. If the woman decides to go on breastfeeding, they have this high chance of transmitting as high as 25%. So the most important risk factor for transmission has been the level of her viral load in the maternal plasma as well as in her breast. So these are studies that actually done as a result of identifying the benefits and risks of antiretroviral therapy that is used during perinatal or during pregnancy. And they have concluded that antenatal antiretrovirals were used during this time resulted in significantly low rates of early HIV transmission. Okay, on the other hand, these studies has detected effects of highly active antiretroviral therapy. They checked on the duration, and this study has said that comprising 730 women, it increases the risk of AMPCP by 8%. So they concluded that the late initiation of ART is associated with increased risk of maternal to child transmission. So they are recommending strategies are needed to facilitate earlier identification of this HIV-infected women. So what are the ART regimens that we have to use? Okay, so our Department of Health, the local Department of Health uses the WHO recommendation of using the once daily fixed dose of three antiretrovirals, that is Remdesivir, Lamivudine, and Pathogens, okay, as a first line ART in pregnant and in breastfeeding women. It is a one daily fixed dose given for ease of implementation, harmonized regimens, increased coverage of ART, or acceptable and sexual prevention benefit. So ARB should are recommended also to be started for life, okay, or should be continued for life rather. Okay, and the rationale for this recommendation is first as evidences of a clinical benefit of the antiretroviral therapy, even though there are reports of a high CD4 cell count. Next, it has an additional protection or extended protection against mother to child, just in case the mother intends to get pregnant for succeeding pregnancies. Thirdly, to prevent possible HIV transmission, just in case your partner is still negative for this infection. And lastly, overall decreasing costs of ART regimens and increased operational visibility in many countries. We also give infant prophylaxis. Okay, so the recommendation is to give the infants of these mothers who are receiving ART, and they should be breastfed and receive 6 weeks of infant prophylaxis using this regimen. That's what we have and are globally available. Okay, so they have mentioned that the efficacy of infant prophylaxis is actually complicated by variables such as maternal ART regimens. Okay, so the issue of if these women has actually, our pregnant women has started ART time or has just started ART recently. So these are the things that we take into consideration and whether the mother will decide to breastfeed or not. Okay, so an infant given antiretroviral prophylaxis is effective when used in combination if the mother also had her maternal ART during her pregnancy. However, in the absence of maternal therapy, meaning this women was delivered without any antiretroviral therapy, infant ARV post-exposure prophylaxis is critical for reducing mother-to-child transmission. Hence, these things should be properly observed or properly explained to your patients, the mother, to the family, so that there will be some interventions and strategies to further decrease possible perinatal transmission. So factors such as safety in pregnancy should also be discussed with your patients who will be given this ART. Okay, so these are the identified medications we've been using. These are the known and identified adverse reactions that a baby can actually have. So your tenofovir shows renal toxicity, adverse birth outcomes, and effects on bone density, and your efavirenz, which is considered a category C drug in the pregnancy, can cause malformations such as anencephaly and microcephaly and neural leakage, which is very important. Okay, so for the safety, the prevalence of overall birth defects using retinopathy in the first trimester was actually 2.4%, and did actually not differ from the general population. Okay, and the risk for neural defects in the case of perinatal is limited only during the first 5 to 6 weeks of pregnancy. These are common in patients who already on ART before they get pregnant. But overall, the known benefits of combination antiretroviral therapy for women outweigh the fact that the known potential risk. So it's still beneficial for these women to start the antiretroviral as early as possible. Some other issues are adherence monitoring. Okay, so these are mentioned a while ago by our previous speakers that adherence is a very important factor in the management or prevention of mother-to-child transmission. We have to identify these women and should be able to counsel with regard to the adherence to their medications. It is implied that ART should not be interrupted even after the delivery and especially if the mother decides to breastfeed. That should be assessed, and of course, every time you have your prenatal checkup, you still have to check these things that are during the prenatal checkup. Okay. So there are also issues with regards to development of resistance. This is a study that was presented that already identifies level of resistance. And this is a local study that was presented with the use of our recent regimen. The recent regimen that we are using, within 1 year, a patient can already develop resistance. So these are also factors that we consider in deciding the other strategies and prevention techniques for prevention of mother-to-child transmission. So locally, there are already 66,303 people living with or diagnosed cases or cases of HIV and AIDS in the Philippines. Now, so if you're going to notice, the number of pregnant women are still very low. As of this time, 315, only less than 1% from the total population. So more than the half of this population, or the local population, are already on antiretroviral. Okay, so 95% of these people living with HIV are still using the first line regimen, and 4% already are using the second line regimen because of evidence. Maybe that's the regimen that's appropriate for them and because of the possibility of resistance in this group. In our local data, which is the local number of deliveries of people living with HIV from 2014 to 2019 at PGH, we had a total already of 86 patients, or mothers who delivered since 2014. Okay? So there was almost the same or almost increasing. Yeah, this is for the first 6 months, 2019. There's almost the same number of PLHIV deliveries. So what is important here is many of the patients are still discovered during the prenatal checkup. And this is because we offer screening to these women whom we see during prenatal checkup. So ART were actually started, many of them were during pregnancy. So much of their information, since most of them were actually diagnosed during pregnancy, a lot of the profile of our patient comes into us and not knowing their HIV status, or not considering that they have an HIV infection already. Okay, so during this time, we start the antiretrovirals. We all know that the use of antiretrovirals in the prevention of mother to child, but still majority or almost half would be started during the third trimester. And we all know that from the previous slides that I mentioned, that it's important to start the antiretroviral as early as possible to prevent perinatal, to suppress the virus of prevention of maternal to child transmission. Most of them doesn't have a viral load because late in pregnancy, or these people cannot afford to do this viral load. And only 6 were had undetectable, and 4 had already less than 1,000 copies per minute. And so these are the issues and concerns that we have to address when actually taking care of these pregnant women with HIV. First, we have to discuss with them what are the maternal effects, possible maternal effects, and compliance, eventually the compliance with therapy. Our pregnant women has a lot of things that they develop when they are pregnant. Some of them are still having this nausea or vomiting whenever they are in the first half of pregnancy. Starting ART during this time would not be appropriate for them. You were able to give, or were able to prescribe this ART medications. However, we're not sure if these women are really taking this medication because of the effects also of the pregnancy, the physiological effects of pregnancy during this time. So pregnancy outcomes, you have to involve them also with regards to the effect of this antiretrovirals that is being given. There's reports of high risk of preterm labor upon using of your antiretrovirals. So safety of these drugs are also being discussed properly with these patients. Of course, we have to discuss what will be the effect of these antiretrovirals when taken by the pregnant woman. Always question of women who are pregnant is what will happen if I take this medication, what will happen to baby. Okay, so for drug resistance, again, we have to be particular with this. We have to go back again to the adherence. We have to explain to these women that we have to take with good compliance their medications, otherwise there will be development of drug resistance with our community. So other factors that we have to address, the need for the prevention of mother-to-child transmission would be first availability of antiretroviral drugs in most of our institutions, as far as those who would really cater for deliveries during this time. And of course, the delivery of antiretrovirals, are they available? I mean, if they are available, are they, can they be accessible also? Accessible to as far as these units, no? Or areas wherein we could anticipate possibility of HIV infection during pregnancy. Okay, so I think that's it. And as a message, it is true that there are a lot of challenges that still ahead with regards to HIV in pregnancy. Again, as I go back, the challenge will always go back to its root because there's still no cure. There's no cure for HIV infection, though there are many ways on how we can always prevent maternal to child. And the bottom line here is all we do not want, we want zero transmission for possible mother-to-child transmission. So we have to individualize all our patients. Okay, so we have this ways, all the matter and recommendations with regards to prevention of mother-to-child transmission, the use of antiretroviral agents during pregnancy is just one of the strategies that we can actually use, or one of the yes, the strategies in proper prevention. We have to identify them early. We have to, it's not just to identify them, but we have to address their issues also so that they will be able to, we are sure that they will take their medications with good compliance. And they will follow. They will follow. Eventually, as this open-minded discussion towards the future, for the next step of interventions that she will decide regarding the mode of delivery, the choice of lethal meeting, and so on and so forth. Again, I think we are all one. Everyone who's inside this room is consistent or unanimous again. Your interest, showing your interest in the prevention of mother-to-child transmission. Again, we're done with the 2015. We were not able to achieve that goal that no baby will be born with HIV. As of now, we are still happy with the results that our first speaker has mentioned. There's only one baby that's been infected. So as of now, we really can tell which among our interventions has actually made the prevention. But combining all these interventions will be the best approach, which is best for a specific patient, so that we will be an HIV-free country. So we will not be the same as that in Africa. We have all the time to prevent this transmission, so we should do it now. Thank you very much for your time.
Thank you, Dr. De Mesa. Are there any questions?
Erwin, can I just find out, I don't know if I missed it in your talk, but um, I know there are certain institutions that already implement an opt-out strategy for HIV testing among pregnant women. So how widespread is that intervention, and is there any hope of actually implementing it at least in local government units where people access public health care for their prenatal checkups?
Ma'am, we have already delivered the information at least to all obstetricians through the Philippine OBGYN Society, as well as the midwives that we are under with, that to offer HIV testing in all pregnant women. So as a matter of fact, we get a lot of referrals actually from from the health centers because they implement that. Unfortunately, there are only certain areas like ECPs who has that HIV testing. There are still a lot of AOH hospitals whom the HIV testing are not readily available. So factors here also are actually the cost of the testing. Some POH hospitals will also still have cost with regards to this. And, these are actually the dead limits. So again, another factor would be the availability of the staff who does the counseling. Of course, in an usual setup in a government institution, if you do request for an HIV testing, it will take time. That will be additional time. There's enough. I mean, there's a long time for them to be seen. And then, if you request for an HIV testing, it will take additional time. Commonly, these patients, upon request, will just have the test and then will go back some other time kasi gutom na, no? They're already hungry, they will just go back, and then the following day there will be a long list for this. So I think we should be able to address this. These patients would agree. Seldom that we see patients going for the opt-out. I think it's more of the problem here. It's more of the availability of the test and the accessibility.
So I'm trying to imagine the scenario. Like I know in the city of Manila it's available. And I've seen like moms bringing in their results, not just for HIV testing, but for the other STIs. And they need you to help them plan for what to do with their infants when they're born. So I was just wondering, so if City of Manila is able to implement it, then I guess it's point of care testing, it's just a rapid test. So parang hindi ko ma-imagine na mahirap siyang gawin.
It's difficult, especially kung hindi po, if the information is not coming from the authorities also. If the institution is not practicing such, then it would be difficult to do this practice. In private practice, there are some, but we can't oblige everyone to offer the test. But then again, it will be a universal. But what we practice in was the recommendation in our CPGs to offer it. To routinely offer it together with the other category of STI screening tests. So there will be no problem with that. However, the emphasis, because if another problem that I see, if you request for a syphilis and the hepatitis together with HIV, the HIV determination is in a different venue, not on the same laboratory. So that will be additional.
Dr. Valim.
Good morning, ma'am, sir. I just like to provide some updates on the law. The HIV/AIDS Policy Act. By the way, ma'am, I'm from the Department of Health. The HIV/AIDS Policy Act actually, in the earliest versions of the draft law, put in the opt-out as a method of testing the pregnant women, but it did not flourish. And so the latest version is doing provider-initiated testing and counseling. So it is now the duty of any health service provider doing antenatal care service to really provide the information to the woman and convince the woman to undergo HIV testing. So that is the current version of our law. And yes, but that is a universal offering. So it might be tedious, it is labor intensive for a midwife to do counseling to all pregnant women. I think in the average in Manila Health Department, they're seeing 100 or 150 of them in a day. So that really is it's a nightmare to the midwives, but that is the law. The law may be harsh, but that is the law. And at any rate, I would also like to share with you some data on the performance of the National Capital Region. So we are focusing our universal screening to pregnant women in the National Capital Region and Cebu City. But what data I have is only for the National Capital Region. In the whole of 2018, the public health facilities were in 17 cities, we are able to test 107,000 pregnant women. And only 30 of them turned reactive. And 30 of them turned reactive, and 17 of them were confirmed HIV positive, and 16 of the confirmed HIV positive we're started on treatment. So that's the data so far we have for region, for the net for Metro Manila.
Thank you, Dr. Belima. One more question.
Thank you. Magandang umaga po. Girlie Contino po. Matagal nang case management of people living with HIV, particularly women, pregnant women. Doc, may isa akong concern kasi na until now, there is actually parang reluctance of OBGYN to handle cases of pregnant women. Kailangan pa namin i-refer sa mga specialized facilities that handle women, pregnant women with HIV. Very, very few talaga. Hindi pa po lahat ay tumatanggap ng mga ganitong cases. Paano po kaya ito, Doc?
Hi, Ma'am Girlie. Last week was counseling, right? 2013. Yes, thank you for that information. Yes, I admit there might be some hesitations for some obstetricians really to handle HIV cases, but rest assured that we are doing things on how to bring down the information to our society and to address these issues. Of course, together with everyone, we also actually had that experience before when we were first handling HIV infections. Delivering HIV cases. It's just we're fortunate that we were the ones who were first exposed to these conditions. But we are doing a lot of things really on how to bring down the expertise or the information to our colleagues. So that every obstetrician, every obstetrician for that matter in particular, will be able to adeptly be able to handle or deliver on HIV infected.
Are there any more questions? There are none. We request Dr. Mario to award the certificate of appreciation to Dr.
Thank you
Dr.
very
De
much.
Mesa. And Dr. De Mesa, if you can sign our commitment board while Dr. Mario reads the...
This certificate of appreciation is hereby given to Dr. Erwin de Mesa for his in appreciation for sharing his valuable insights and expertise lecture on the topic maternal and fetal outcomes of therapy in HIV-infected pregnant women during the HIV Summit, Know Your Epidemic or Your Response, given the second day of August 2019, signed by Dr. Annalisa Onglim and Ross Lee. Thank you.
Thank you. So for our fourth lecture, this will be a related subject also with the earlier lecture of Dr. De Mesa. This will be the prevention of maternal to child transmission, which will be delivered by Dr. Marimel Reyes Pagkatipunan, a consultant of the Infectious and Tropical Disease section of the Department of Pediatrics